Last year, it came across that Welsh services have amongst the lowest resource in the UK, therefore have the lowest whole-time equivalents in the UK. A stat I like to say is, in my managerial job in the Health Board, I manage more physiotherapists for Aneurin Bevan Health Board than there are child mental health professionals in the whole of South Wales. And therefore, we're able to see fewer patients. Unsurprisingly, this has come up with a whole load of concerns. So there's been expert investigation after expert investigation which will identify the problems with inconsistencies, the way we manage risk, the way we manage people who aren't brought to their services, problems of children on adult wards. Perhaps we'll talk a little bit more about that later. The whole transition from adult to mental health services, the availability, the sheer number of beds for under 18s, clearly a waiting list, specific groups being excluded like children in the youth offending service, the deaf. What happens out of hours? Most out of hours services have one child, most health boards have a single professional on board with no access to beds out of hours. There's been the publicity about children in police cells and after 136. There's been implementations of all-age mental health measures and there's clearly been inconsistency across Wales in how all that's been addressed. So all these are the problems and the noise going, but the questions I ask is, what's happened? How has the resilience of a society changed? How is it that now we have such a rapid movement? I've been a psychiatrist since 1990 actually. I've been a consultant child psychiatrist in 1998. And it has massively changed, and yet society has not massively changed in most things. We are living longer, we are broadly healthier, we manage infectious diseases better, we are by and large wealthier as far as the number of possessions most people have, yet these things are escalating in a way that if it was a physical health problem, you'd be wanting to ask questions, people will be saying this is a crisis. The World Health Organization has said the biggest challenge for the health services in the developed world from across the world from 2030 is going to be mental health, not physical health. One of the questions I asked, however, is mental health language the correct way to going about it? One of the big things I've noticed through my career is actually the profile of mental health services has increased enormously. Various policies have come through to say how important children's mental health is, adults' mental health is, how important and fundamental it is to reducing stigma. But actually, to a certain extent, I feel that has disempowered people, because the assumption is if it's important, therefore it must be something a specialist must do. And actually, therefore, in a way that you don't get with physical health, the point that people feel disempowered is much lower. We've lost the ability to discern between normal fluctuations in emotional states. You know, normal life does have some ups and downs. And if we use language too often, like depression, when it's inappropriate, we disempower people from managing themselves rather than empowering them. At the other end of the spectrum, diagnosis is really important. Accurate diagnosis is really important. But as a trainee, I was trained to look at diagnosis in what was called a formulation. In other words, why does this person, from this background, from this family, have this problem at this time that's not getting better? Because very often the answers to the treatment and care package lie in all those other areas rather than something nice and neat regarding the diagnosis. So we need to keep the individual and the context central to the way we manage, not have a reductionist thing. And getting that balance is really hard. You want to have equal esteem with physical health. Personally, I think physical health needs to go back to what was called holistic medicine. But we need to cling on to that rather than become too reductionist and simplistic. We know what works though. We know what makes people resilient, what makes people being able to cope. Lots of work has been done that if a young person or adult of any life has a purpose in life, so has a known role, knows what their job is, has ambition. We know if they feel competent at something. So being able to play sport, being good at music, doing something that they feel they can do well, as opposed to some, and it tends to be non-academic, because if you're good at something academic, you tend to get a point where people either tell you are average or you fail. I was quite good in school. I passed exams and I got to medical school. I then became an average medical student. I could have thought that was average. I didn't, but you need to know, you need to have things that give you a sense of confidence. I can do this well for my enjoyment. And you need to be part of a social grouping as well. We know these these things are the important things on which resilience and positive mental health are built. And hopefully during the course of the day, whilst we learn about some of the specialist stuff, we'll also learn about some of the things we as just members of society can do to promote these, not only in young people, but people of all ages. The other thing to remember is actually, this is based on Maslow's hierarchy of needs, is actually we tend to overcomplicate therapy or go to therapy straight away. Therapy is built on some foundations, and if a child doesn't feel safe, if a child is unwell, if a child doesn't feel cared for, you can't therapy your way out of that. And some of the things is how we deal and look after our young people to make sure that those things are in place. And I don't like the referral model because it implies passing the responsibility over to somebody else. I think the idea is just like that's a layered approach that builds from the bottom up, you need to be working across those 5 layers, and people need to be addressing, making sure people are physically safe and fit and well and working in a more collaborative way. And with the concerns and the risks around children's mental health that are always trumpeted, actually sometimes people let go because they're too afraid. So what have we done in Wales? You might have heard about Dame Professor Sue Bailey. Primarily the review is looking at the NHS. We're looking at a variety of things though. We want to sort the problem out, we don't want to answer the report, if that makes sense, because very often reports can skew you to only deal with a part of the problem that the particular author of the report picked up, rather than getting the fundamentals right. So we're looking at a variety of streams. We're looking at specialist services. We know we need to invest in them, we know we need to expand in them, and we're hopeful that in the next few weeks there will be some positive news on that. We know there's issues such as ADHD, ASD, learning disability, all those sorts, which again need a proper focus and proper services that require more than just specialist CAMs, but also other professionals in the child healthcare and educational local authority. We want to properly start looking at what are the things we can do in the early years in prevention. Ian's going to be talking about, with some of his colleagues, about maternal mental health and perinatal stuff. Actually, this is key, because if you want to have a healthy population, if you want to have a resilient population, you can do 50% of the job by the time they're 3. You can do about 75% of it by the time they're 13. And in fact, if you don't do it that way round, you're always struggling. We're doing stuff about early intervention, so we know there are some high-risk groups that we need to do some simple things assertively early, rather than wait until they are self-harming and causing trouble and we can't find anywhere to place them because the risk is so bad, and we're looking at beds in Scotland because they're the only ones in the UK available. We need to develop the workforce and the leadership across sectors alongside patient service users, because there isn't a huge queue for my job. I have to say, there isn't a huge queue for my psychiatric job, there certainly isn't a huge queue for my NHS manager's job, and there's not a huge volunteer force saying I'd like to speak to MPs and civil servants about mental health services. Not because it's a really horrible job, but because it's a tiny pool. Actually, we all know each other. I see familiar faces that I come across an awful lot, because there's a sort of core 200 that you come across for everything and you bump into. Most importantly of all, though, we're looking at making sure the young person's voice is central to this, and we're looking at how we work with various agencies that represent young people, but also how we look at young people who don't access services, because we know we don't get 1.3% of the population being referred to us.